Good afternoon. It is my pleasure to introduce Dr. Jennifer Marks. She is at Health One, and she is a thoracic surgeon. A Colorado native, Dr. Marks received her medical degree from the University of Colorado School of Medicine and completed her surgical residency at New York Presbyterian Cornell Medical Center. Sorry if I butchered that. She went on to receive advanced training at MD Anderson Cancer Center, where she became passionate about the treatment of lung and esophageal cancer. She completed research through Memorial Sloan Kettering Cancer Center and co-authored more than 20 publications, chapters, and abstracts on a wide variety of lung and esophageal conditions. She is the co-chair for the Sarah Cannon National Thoracic Work Group and also serves on the Health Economics and Outcomes Research Committee for Sarah Cannon. She's also the chair of the Cancer Committee at the Medical Center of Aurora. In her free time, she enjoys running, hiking, and skiing in the mountains of Colorado and beyond. Thank you, Dr. Jennifer.
My name is Jennifer Marks. Like I was introduced, thank you for that introduction. I'm a Colorado native. I grew up on the western slope, a little town called Craig, Colorado, which if any of you are hunters or skiers, you might know because of its proximity to Steamboat Springs, but not many people actually know Craig. I grew up with a father who was affected by lung disease, both pretty severe asthma and then some underground coal mining in his history, which led to a fair amount of damage itself. And so kind of from an early age was aware of having oxygen concentrators in the home and what that meant and how it affected our lives as children and his life as our parent. During my schooling, sort of unbeknownst to myself, I just sort of gravitated towards the lungs and trying to take care of the lungs. What I do is a little different than what most of you have, other than that a few lung diseases are surgical, such as tracheobronchial malacia and or lung cancer. Many of you may have had a lung biopsy to help determine maybe what actually was going on with your lungs if your pulmonologist wasn't able to figure that out just by other testing. So I chose to go into the surgical side of lung disease, and that's what I spend my days doing. I work for Health One here in Denver, so I work for several hospitals. I know Dr. Wyant quite well, so you're very lucky. He's an amazing physician, and I'm very happy for you that you had a good outcome. That is a difficult surgery. We're going to talk today about lung cancer screening. For those of you who don't know much about lung cancer, there are two main kinds of lung cancer. There's non-small cell lung cancer, which is the majority of what we'll talk about today, and then there is small cell lung cancer, which is sort of a different entity. So we're going to talk mostly about non-small cell lung cancer today. Does anybody know when Lung Cancer Awareness Month is? November, correct. Does anybody know what color our ribbon is? Very good. So obviously Lung Cancer Awareness Month gets much less attention and much less publicity as opposed to things like breast cancer or colon cancer. It's sort of thought to be very taboo because of the association with smoking. But plenty of people get lung cancer who were never smokers. And so those of us who work in the field really try to raise awareness around Lung Cancer Awareness Month, which is coming up next month. And just to sort of show you the plate of ribbons, for white definitely being for lung cancer. So lung cancer is the #1 cause of cancer deaths in both men and women, which I don't think many people know. If you look there on the left, you see, number 2, these are new cancer cases. So first we'll talk about incidence and then about the death rate. So lung cancer is the second most common cancer in men behind prostate and the second most common cancer in women behind breast. However, if you look at what cancer kills people, lung and bronchus are right up there at the top. The problem and the reason that that's the case is because we don't find it early enough, and so we can't treat it early enough to where we can have an effect. There are screenings for prostate cancer. I'm sure every man in this room has been to his physician and had a screening for prostate cancer that involves a finger. There are also obviously screening for breast cancer. Probably many women in this room have had multiple mammograms, if not ultrasounds and MRIs over the course of your life to screen for breast cancer. Only very recently has there been effective screening for lung cancer. Lung cancer screening also is not appropriate for everyone. It's only appropriate for those high-risk patients. And so it's quite a different category. If you look at the number of deaths from lung cancer, it's more than the next 3 cancers combined. And so this really is a cancer that's killing people, and we finally have a way to try to find it earlier. So here, just another sort of slide. It accounts for 27% of all cancer deaths in this country. If you look at how much funding goes into lung cancer research, I guarantee you it's in the single digits in terms of other disease sites funding, such as breast or colon or prostate. These are some of the survival rates for non-small cell lung cancer, and you can see it's a pretty dramatic drop-off. You don't have to see what every little bar represents, but if we find your disease at stage 1, and stage 1 is broken down into a number of different subcategories based on actually how big the tumor is, we can keep you alive for a pretty long time. Stage 2, stage 3, stage 4, it drops off pretty quickly. The overall sort of 5-year survival rate for lung cancer, if you throw all comers in there, is very low. It's on the order of 5 to 15%, kind of depending on what you look at. The problem with lung cancer is that we just don't find it soon enough. This is another kind of busy graph, but if you look at those colored lines, the smaller your tumor is, the higher up you get to go on that graph, which means the more you're going to stay alive longer after we find your cancer because we can treat it. So that's the entire purpose behind screening. If we look at trends in death rates among males in this country, thankfully the death rate for lung and bronchus is dropping, which also coincides with sort of big tobacco and us realizing that smoking causes lung cancer. And there thankfully has been a dramatic decline in the incidence of smoking in our country over the last 20 to 30 years, which you can see as a decline in the death rate. Same thing true for women. For a while there, it was very popular for women to smoke, sort of along with women's rights in the 60s and 70s. We thought, oh, we should have the right to smoke too. And so up went the lung cancer incidence rates in women after all of that smoking. We still quite never reached that of men, but also the death rates for lung cancer are dropping among women. Lung cancer in Colorado. So what about in our state? The American Cancer Society estimates there will be almost 2,700 new cases of lung cancer diagnosed this year. Of that, 1,500 of those patients will die. So that's more than half. 60 to 75% of cases of lung cancer are diagnosed at an advanced stage when our treatment options really become palliative. We can't cure lung cancer when we find it this late. The lifetime probability for developing lung cancer for a man, 1 in 15. Prostate is 1 in 9. For women, 1 in 17. Breast, 1 in 8. So not quite as probable as some of the other ones that we think about, but still you can see, second or third on the list in terms of the likelihood of developing lung cancer. So it really is not that uncommon. This is sort of a slide depicting the trend in the 5-year survival rates. If you look down to lung and bronchus, in the 70s, 12%. The 80s, 13%. Now we're up to 20%. We're not doing a very good job. Lung cancer screening really only took off in the early 2010s, and so if we were to look at this graph in 5 to 10 years, hopefully it will be much different as we try to shift the curve when we find cancer earlier. So why should we screen for lung cancer? This is sort of the best little pictograph that you can find. If we find it at stage 1, all those little blue stick figures are going to be alive and they'll survive. If we find it at stage 4, only one of those little stick figures is going to survive and be alive at 5 years. So I don't know a better reason to try to look to find it earlier other than that we can keep people alive if we can find it earlier. In order for a cancer to be ideal for screening, it has to make sense. You're only going to screen patients and put them through that screening test if you're able to find a number of cancers that you're able to do something about. Lung cancer is ideal for screening because it has such a high morbidity and mortality. That last slide I showed you, stage 4, we can only keep one of those people alive because people die from lung cancer when it's late. So it's perfect to try to find it early when we can keep people alive. It happens often enough. I showed you those numbers, 1 in 15 for men, 1 in 17 for women. So that's a significant enough prevalence that we're going to find enough cases to affect people if we screen the appropriate people. We know the risk factors for for lung cancer. I blurted it out, smoking. There are a few others. Radon in our homes here in Colorado, we have higher levels. We know uranium miners, which we definitely have some of that in Colorado, are also at higher risk. But really, smoking is the #1 modifiable risk factor that we can have to affect this disease. Lung cancer has a really lengthy preclinical phase, meaning people will quit smoking. I see patients every day who quit smoking 30 or 40 years ago, and yet they're in my office with a lung nodule. So we have a lot of time to try to find that cancer before it starts to grow. Cancer doesn't happen the year after you start smoking. It happens 20 years later, and so those are the people we got to look for it in. And therapy is definitely more effective in early stage disease. There was way more blue stick figures under the stage 1 side of that diagram than there was on the stage 4. So we find your cancer when it's stage 1, we're pretty confident we can keep you alive for a long time. Fundamentals of any screening test means the purpose of the screening test is to detect disease at a stage when cure or control is possible. We know that the at-risk population, i.e. smokers, is subjected to screening to identify you when you're asymptomatic. We have to find it before it becomes advanced enough to cause symptoms. And then those with a positive screening result need to get worked up further. The characteristics of a good screening test and a good program means it has to be highly sensitive. We have to find what we're looking for, and it needs to be fairly specific. Now, lung cancer screening might struggle a little bit around the specificity side in the beginning, but then the additional testing that sometimes happens after that initial screen is quite specific for lung cancer. We need a screening test to be low cost. We know that healthcare in this country is already incredibly expensive, and so we can't ask people to go spend a whole bunch of money on a screen where we're not even sure if you have the condition. And then it also needs to have a low associated morbidity. So you don't want to put patients through a screening test that's going to hurt them in the end. The goals of screening: increase overall cure rate, find more early stage disease, and keep patients alive for longer. So everything that I've just talked about in terms of screening and what a screening test should be and how it should help the patients, we as the medical profession have struggled with this for years up until, like I mentioned, the early 2010s. We tried for a long time to prove that chest x-ray was an effective way to screen for lung cancer. We tried for a long time to prove that screening with CAT scans was an effective way to find lung cancer. And we were only really successful in the 2011-2012 when the results of the National Lung Screening Trial were published in this country. It finally established low-dose chest CT as a standard for lung cancer screening in high-risk patients. It was a study that compared chest x-ray versus a CAT scan of the chest in high-risk patients to see, can we find it early enough, treat these patients, and improve their overall survival. The study got stopped early because it was so positive, meaning we couldn't ethically continue with the study and only give people chest x-rays because we were finding so much early stage cancer with the CAT scans and treating people, and they were doing so much better that the ethics committee stopped the study. So it was black and white positive. We found that we can reduce the lung cancer specific mortality by 20%, which is huge. And there's actually a 7% reduction in all-cause mortality, because when we look at people's chest with that CAT scan, sometimes we find other things that need to be acted upon that were also asymptomatic that that patient never would have known about. So it was overwhelmingly positive. There was a high rate of false positives in this initial study, but part of that is related to the fact that they called anything over a 4-millimeter nodule positive, which we've now sort of learned to bump that up a little bit and not quite call things quite so small positive. So who should get screened? I think you guys could all raise your hand and answer smokers, but there's actually a certain amount that we've proven that you need to smoke in order to make screening effective in you. And also, what age should we start screening people? And this number will vary depending on sort of the source that you look at, but in general, it's patients 55 to 77 and even a little bit older, 55 to 80, based on some criteria, who either are currently smoking or who have quit smoking in the last 15 years and have at least a 30-pack year smoking history. So that's a term that you all may not understand. A pack year is how much did you smoke a day for a year? So if you smoked a pack a day for 30 years, that's a 30-pack year history. If you smoked 2 packs a day for 15 years, that's still a 30-pack year history. So we know that that's sort of the minimum amount of damage from smoking that patients need to have in order for it to make it effective for us to look for cancers in patients like that. If they quit 20 years ago, they fall outside of that criteria, but that doesn't mean they shouldn't get screened. These were the initial suggestions, and each lung cancer screening program across the city and across the country has modified these a little bit based on local insurance carriers and based on their sort of whichever society guidelines they're looking to. But this is sort of the basic tenets of who we would screen and who is considered very high risk. Here you can just see another one. This one says 55 to 80, quit within 15 years, how much you smoked, and you have to be asymptomatic. If you have a symptom, it's not considered a screening test at that point. You're already looking for something, and so in order to screen, you need to be asymptomatic. Some people worry about the radiation of a chest CT, and is it safe to sort of get screened with the CT more than once because of the amount of radiation? And the short answer to that is yes. Because just by living in Colorado, we get more radiation per year than you would get by going and getting one chest CT to look for lung cancer. So we try and avert that concern when we talk to patients about going to get screened. A mammogram is also almost, if you look at the life of a woman from 40 until moving on, she gets significantly more radiation from that mammogram than she'll get from one lung cancer screening CT at various points in her life. In order to get a lung cancer screening CT, you obviously have to go and sit down with your physician, and there has to be an order for the lung cancer screening CT. You have to meet the criteria that we just discussed, and this is all, of course, in order for your insurance to cover it. There are many programs out there where you can have a self-pay cost, but the vast majority of insurers, including Medicaid and Medicare, will cover a lung cancer screening CT if certain requirements are met. The criteria we talked about in terms of age and smoking history. If you are actively smoking, your physician needs to document that they have spoken with you and at least offered you smoking cessation counseling. Many patients, unfortunately, are not interested in stopping smoking, but we at least need to document that we tried to have that conversation. We know that that's the most effective intervention for lung cancer, is to get people to stop smoking. And then there needs to be what's called a shared decision-making visit, which is really just where you sit down with your physician and you talk to them about the screen, about the radiation, and about what we might find and what the next steps might be, so that you sort of understand, what ball you may be starting rolling by going and getting this scan. None of this stuff is up to you all as patients or as your family members. This is all on the physician end of what needs to be done so that your insurance will pay for the screen. The screening centers are accredited and recognized as accredited centers by the American College of Radiology. It is a low-dose chest CT, which means it is less radiation than you would get for the CAT scans that many of you have had to look at your lungs. The diagnostic centers doing these CAT scans also are required to submit data to a national registry on the lung cancer screening patient so that we can continue to accrue data on screening to prove that it is effective and worthwhile. So I would encourage, if any of you are going to get a lung cancer screen, I would make sure that it is a designated and certified center so that you know you're getting the appropriate screen and that they're following the guidelines that have been established. Screening programs it's more than just a CAT scan and your physician. You need to be sure that if there is a positive finding, that you're going to have a multidisciplinary team of physicians looking at that positive finding and determining what the next steps might be. The last thing we want to do is do a bunch of unnecessary follow-up imaging or procedures on patients without having experts in the room to look at that nodule and really decide what might need to be done. Our team often consists of pulmonology, myself as a thoracic surgeon, the medical and radiation oncologist, as well as the radiologist. We look at CAT scans of people's lungs every day, and so although we're not perfect, we're pretty good at deciding which nodules need to be intervened upon and which nodules we can just keep an eye on. Positive screening findings are also presented at a conference, like I mentioned, to reduce unnecessary procedures and/or expedite further testing if there really is something concerning that we need to evaluate. Time from diagnosis to treatment matters in lung cancer. There was recently an article published saying that every delay of over a week beyond the first month from your diagnosis delays your survival. So it's not really a disease that we want to sit on once we have found it. We really want to intervene quickly. What about some of the harms of screening? What's the possible downside to going and get screening if you qualify? Well, it could lead to further diagnostic procedures. Often, sometimes the stress of going to get screened is enough to keep people away. People have smoked for, let's say, their whole lives, and they're worried they might have it, and they may just not want to know. And so patients often will just not go, or being afraid of what further workup might happen if they do find something. There's also this question of overdiagnosis, and are we finding cancers at such an early stage that the cancer really never would have affected the patient? And I think that's pretty much been sort of settled in my world, at least. There are some radiographic findings that are less concerning than others, and those might be some of the things that we would watch, but again, only under the sort of close surveillance by a qualified team do we recommend, really doing that. This just kind of shows it's really small, but it sort of shows the number of procedures that had to be done during the lung cancer screening trial that wound up not being cancer. And thankfully, the vast majority of nodules that get identified on these lung cancer screening studies are not cancer, but we still need to look at them and follow them to prove that and to know that. The problem, and the reason that every chance we get we're out here talking about lung cancer screening, is only 19 out of every 100 people who qualify for screening actually go and get screened. So we're only really reaching a fifth of the patients that we need to be reaching in order to really try to shift the survival curve for lung cancer. So I would encourage you to, if you take nothing else away from my talk today, is go home and talk to your friends and family members and loved ones who smoke and have them see if they qualify for screening and have them pick up the phone and find somewhere that they can go. So some of the limitations of our current evidence around lung cancer screening, you saw that in a couple of the criteria, the upper age limit was different. Is it 77? Is it 80? Is it 85? Really, age is more than just a number. If you are, 85 in calendar years, but physiologically in great shape and doing well, then yeah, we're still probably going to screen you, because if we find something, we can still treat you and potentially keep you alive despite the fact that you might have a cancer. Some of the radiology parameters in terms of we've learned of what is really positive from a nodule standpoint and what should we move forward on. There's a very established set of guidelines for the radiologists when they're reading these reports. It's very similar to the mammography guidelines when they're reading out suspicious findings on a mammogram. So everything has been pretty well standardized so that we know at what point do we need to intervene. And then there are a number of risk prediction models that are being developed that take into account other factors such as the presence of underlying lung disease, family history, sex, race, and body weight that sort of help us predict, again, how suspicious a nodule may or may not be. You can see this is obviously too small for you all to read, but it's a number of societies up and down the left from the United States and Canada, both surgical societies, cancer societies, as well as pulmonology or medical societies that sort of show their varying recommendations of who should get screened. They're all pretty similar. There are some individual nuances, but if you think you know anybody who's close, it's worth getting a physician's input, and having that screen done is really the sort of short answer for that. So I realize I've said lung nodule a number of times, and maybe some of you don't know what a lung nodule is. I should have put these pictures first. This is a CAT scan over here on the right, and your heart is sitting here. The gray part is your lungs. They're gray because they're full of air. You can't really see this move, but there are probably 100 pictures in this CAT scan as a whole, and this little spot right here, this white spot, is a lung nodule. Here's just a cartoon depiction. This one's out on the edge, but you can have a nodule anywhere in your lungs. A nodule means that it's less than 3 centimeters, and it's largely solid, the way this nodule is here. It's just another little picture of what a nodule might look like in someone's lung. And there's another one that's a little bit larger. So where do lung nodules come from? I mentioned that the vast majority of the nodules that we find are not cancer, and that's true. They can be benign. They can be from an old pneumonia that your body had that it sort of just turned into a scar, and that scar looks like a nodule. They can be inflammatory in nature. There are several different fungal conditions that are prevalent in this country, mostly in other states, but in the Mississippi River Valley or down in Arizona that can give you lung nodules that can be concerning. I meant that they can be a lymph node. And there's a number of benign things that you can have in your lung that aren't cancers. But if we don't look, we'll never know. And then this few number of them are malignant, and they can be either a primary lung cancer, or it can be a metastasis, a spread from another cancer that you may have had elsewhere. Colon cancer, breast cancer, renal cancer, all of those cancers, sarcomas, like to send cancer cells to the lung. And if we find that early enough, sometimes we can take those out and affect the survival of that disease as well. So when we look at a lung nodule, we try to guesstimate is it really concerning or not. We take into fact the patient's smoking history, the size of the nodule, the shape of the nodule. Is it solid versus just kind of hazy in appearance? Where is it? And more importantly, is it growing over time or is it staying the same size? Most things that are malignant grow. If we watch a nodule in a patient for 2 years and it doesn't grow, there's an over 95% chance that it's benign. So we're not going to do anything about it, but at least we know it's there, and we've looked at your lungs, so we've ruled out you having a cancer that we didn't know about. Is a biopsy necessary for every nodule? No, I just mentioned that it's not, so it depends. And they can be done minimally invasively the majority of the time. So a biopsy doesn't mean moving straight ahead to surgery. Sometimes you can have a bronchoscopy, which many of you may have had. We have very fancy ways to do bronchoscopies now where we can navigate out to the edges of the lungs, even outside the airways, and try to biopsy these nodules. Or you can have a biopsy that is guided by a CAT scan where you sort of lay on the table and you're going through the CAT scan to get your biopsy. Just a little cartoon depiction of one of the ways to use bronchoscopy to get a biopsy, or sticking a needle in from the outside on a CT scanner to try to get a biopsy to understand what the nodule is. Sometimes people say, you know what, I don't care what it is, I just want it out. Some people are very uncomfortable knowing there's a nodule in there, and they just want to take it out. Well, thankfully, for what I do in 2019, we can often do this minimally invasive, which, yes, does still mean surgery, but it means small incisions and a camera. It doesn't mean opening up the chest from the front or necessarily opening up the chest from the side. It does mean going all the way to sleep. You do have to have general anesthesia. I'm sure many of you may have had that for various bronchoscopies. Small incisions, we go in there, we take the nodule out, we send it to the pathologist, and then we've sort of done a one-stop shop in terms of diagnosing the nodule and treating it at one time. Obviously, if we find out that it's a cancer, we do effectively what is a cancer operation, in that we take the nodule and we take lymph nodes so that we can make sure and get all the information that we need. Video-assisted thoracic surgery is one way of doing things minimally invasive, and you can see on the bottom part, the picture of the patient, you really can't even see those incisions. There are usually 2 to 3, usually centimeter-sized incisions, and we kind of turn you on your side, and we sneak in between your ribs with our cameras and our instruments, and that's how we remove the nodule. Patients do really well with this surgery. There is obviously some pain, but much less than if we had to make a large incision and get our hands in there in between your ribs. You can see this sort of comparison here. The picture on the left is someone who had to have a thoracotomy, which is the way that we used to have to do chest surgery, and we still do for some operations, compared to obviously the VATS incisions that are much smaller, and it makes recovery much, much easier. We can also use something called the robot, which is the sort of not really new anymore, but it's a device where you dock various arms of the robot in those small incisions on the side of the chest. And then here's the surgeon sitting over here in the console. The patient's over here with the camera, and all these instruments are the arms of the robot that the surgeon is controlling from this console. The main advantage to the robot is that when I put my head in this little window, my camera view is a 3D view of the inside of that chest. And so it's a significant advantage over the video assisted that I just mentioned, where you're really just looking on a screen and it's a two-dimensional view. And so I'm sure at some point in your all's lives you've seen, 3D movies or 3D pictures. It really is like open surgery, but you're not inside the patient's chest, but you can really dramatically see much, much better, and it's amazing what this technology is allowing us to do minimally invasively. So how do you breathe during surgery? Well, we put a special tube down your airway that actually has two sides, because the lung that we're operating on, we actually have to deflate, because if I don't deflate that lung, I can't see anything. There's usually no room inside your chest between the outside of your lung and your ribs. So if I were to put a camera in there without deflating your lung, there would be no space. So we deflate the lung that we're operating on, and we breathe for you with your other lung via this special breathing tube that goes in. It really just winds up giving patients a sore throat because it's a little bit bigger than most breathing tubes, but that's how we're able to breathe for you while we're operating on your lungs. These are just some pictures of what things look like in the operating room. This screen you see here on the right, that's what I was saying, that's the two-dimensional view for after a videoscopic surgery. And sometimes we make one of the incisions a little bit bigger because obviously we have to get out the piece of your lung that we're taking out. And we can't squeeze it out through a little centimeter-sized hole. So we have to make one of those incisions a little bit larger to get out the piece of your lung. And there you can see just a depiction of a surgeon holding a small piece of the lung that they have removed. How much do we take? Well, it depends on how big the nodule is and where the nodule is. We can take anything from just a small little piece, a wedge resection. A segmentectomy is a little bit larger piece. It's actually an anatomic resection. For many lung cancers, we have to take a lobe of the lung. You have 3 lobes of your lung on the right and only 2 on the left. There's not quite as much room in your left chest because of your heart. And sometimes in advanced cases, when we don't find the cancer soon enough, we might have to take out the entire lung, so a pneumonectomy on one side. And believe it or not, if you're in good shape and you have good lungs, you can live on one lung. So it's something we do hopefully less and less often now that we're screening patients, but sometimes you have to take the whole lung out. The advantage to being able to do surgery using small incisions and the camera, it is now the standard of care for early stage lung cancers, and we have proven over and over that the outcomes are better compared to one of those big, 10-inch long incisions that I mentioned. There's less respiratory complications such as pain or needing to go on oxygen continuously after surgery. It hurts less. You get to stay in the hospital for a less amount of time. You get to go back to work sooner. And there is better compliance with other therapies that you might need for your disease after surgery. So what can we do? What can you tell your friends and family to do? Number 1, stop smoking. Your lungs are actually healthier 48 hours after you stop smoking. It's sort of ongoing damage that happens. We're learning more and more now that our lungs and our younger generation's lungs are being damaged by vaping. Vaping is obviously different than smoking a cigarette, but it's also not healthy for the lungs. And so I would say stay tuned in terms of questions about that because it is not good for your lungs. The risk of getting lung cancer starts to decrease very shortly after quitting because you stop continually harming your lungs. We have cessation services at most of the Health One hospitals in town. Obviously, National Jewish does as well, as does the university. So seek out a cessation program. It is hard to quit. That is no joke. And many people can't do it alone. But there are professionals out there who are trained to help, and they will be happy to, help. Get screened. If you know anyone that has the history that I mentioned and they meet the criteria, go get screened. It's better than anything else that you can do. And it's, the number needed to screen to find a cancer and save a life is less for lung cancer screening than it is for colonoscopy or mammograms. So it's a more effective screening test than the other widespread screenings we have. Seek out an experienced team to help with any diagnosis or treatment that might be necessary. I'm sure you all have great teams that help you treat your lung disease now, and a team to treat cancer is just the same. You need the right people on your team. And again, we can reduce mortality and shift that curve towards many more early stage diseases if we just can get everybody screened. So that's all I have. I'm going to thank and acknowledge all of y'all for coming out today on a Saturday, and I'll be happy to take questions.
Thank you so much for talking. I had 2 questions for you because my father definitely falls in that category. So the first one is, how does pack year translate to cigars or pipes?
It doesn't really, because it's a little bit different, and it's not the cigars and pipe smoking is obviously different because it's usually not the amount of smoking as a pack of cigarettes. But I would say that if the smoking of a cigar or a pipe was consistent, like every day or every night, then he would likely still qualify for screening.
Okay, and then the second question is, let's say that miraculously he said, okay, I'll go get screened. Oh, he's in a different state.
So all he needs to do is mention it to his primary care provider.
Okay.
Insurance is everywhere, and every state has these screening programs. So if he asks, I'm sure that his primary care provider will know who to plug him in with.
Thank you.
Sure.
Hello.
Hello.
I've had lung cancer like 10 years ago, and I was 3B. So I'm really doing well.
You are doing excellent.
I think so.
Yes.
Anyway, now I have, well, several nodules, but one I think is kind of big. It's like 1.4 centimeters, and now they want to do another PET scan, and I sure don't want to light up like a Christmas tree. And they want me to wait 6 months to have the PET scan, and I'm thinking maybe 3 months.
I would say that I'm sure that your team is very well experienced, and if they think 6 months is okay, there must be a reason. If you are uncomfortable with that, it's certainly your right to ask your team to do it sooner, and I don't think they would object.
Well, the NP wanted me to do it like the next day.
I would say call your team and talk to them. I bet they'll listen to your concern.
Okay.
Hi. Is it on? Okay. I missed your point about whether or not to be asymptomatic in order to have screening. What I just don't remember what you said.
So any screening test is defined to pick up disease at a point when it is asymptomatic. And so you don't go get a mammogram after you found a breast lump, right? You go then, at least not a screening mammogram. So the point of screening is to find people before they have symptoms. Lung cancer is often found incidentally, even when it's more advanced in stage, because it doesn't often cause symptoms. So if you go to your doctor with a cough, you can get a CAT scan, but it's not going to be a lung cancer screening CAT scan.
What are the concerns, if any, with environmental exposure to 5G technology?
I'm not familiar with 5G technology.
It's like the body.
Oh,
Well, no, it's just they're putting in the new towers. 5G technology is what the body scanners are at the airport.
we don't, there's no data to suggest that that's concerning at all. There are some cancers that can be associated with prior high-dose radiation. If people have their chest radiated for Hodgkin's lymphoma or women have radiation after breast cancer, we can see what we call scar cancers a number of years later. But in terms of the airport and cell phones and all of the other radiation that's out there, we don't know of any increased risk.
For someone that's been diagnosed with lung cancer or breast cancer, how do you go about developing your multidisciplinary team with all of these expert doctors?
So I would say start with the physician that you currently have, and I bet you already have a team. You may just not know about it. At most of the hospitals in town, there are these multidisciplinary teams, and you may have been presented at a tumor board, and that just maybe was not communicated to you. I would say if you ask those questions and the answer is no, then I would maybe ask if they have the resources to have a team like that. It's been shown in many cancers that it's beneficial to have that multidisciplinary team and that tumor board evaluation. But I would bet that you may have that, you may just not be aware of it.
Hi, I'm a pulmonary fibrosis patient. It's me over here.
Yes, thank you.
Once a year, I get a CT scan generally. Sometimes more than that if I'm in a medical trial for a base reading. So my assumption after watching this is they're not only looking at the progress of the fibrosis, but somebody will be looking for those nodules.
Absolutely.
And would let me know.
Absolutely.
Okay, thanks.
Go ahead.
If my nodule turns out to be malignant, with this PET scan, since it's still in my lung, is that a metastasis or is that just another piece of it?
It depends. Likely at your point, with your disease having been 10 years ago, it may be a new lung cancer. You may just be that unlucky to have gotten a second one. But it's hard to know, but they can, usually metastasis happen much sooner than 10 years. But were you a former smoker?
Yes.
So the damage to your lungs that caused your initial cancer, damage the rest of your lungs also. And so it's not uncommon for people to get more than one lung cancer when you've had such a great survival from your initial lung cancer.
And they would treat it with different chemo or whatever.
Potentially.
Maybe they could just cut it out.
Well, I'm sure your team would discuss the options and what they think would be the best for you.
What can we do to help on that 19%
Yeah.
factor?
It's hard. There's a big stigma associated with lung cancer. And like I mentioned, people are afraid of going to get screened. All of the professional societies that work with lung cancer and surgeons like myself, we just really try to promote screening to friends and family because those are who will actually push the patients to go. They don't want to listen to me. They want to listen to their wife or their daughter asking them to go get screened. And so it really is just push, 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 and reassure them that it's covered by their insurance and reassure them that most of what we find isn't cancer, but there's also a fair amount of peace of mind to go and get screened and know that you're okay despite the fact that you may have smoked for 20 or 30 years. So I would say just talk to people. It's really the best thing to do.
Last year, about this time, we returned from vacation, and I had a very bad cough, and it continued. I saw the doctor twice for it, and then the third time, I went about something else. I said, that cough never disappeared, really went away. And so he said, let's do a chest x-ray to test for pneumonia. And they did find a mass, and it turned out to be cancerous. So and then I'm a non-smoker. I grew up around a lot of people who smoked. When I was a young adult, everybody smoked. I didn't, but
Right.
so I would not have fallen in the parameters of those studies.
Correct.
But it was very good that I had that chest x-ray and
Yes.
found out.
You're right, and the reason that we don't screen everyone the way that we do with mammograms and with colonoscopy is that it would dilute the number of cases that we would find, which would mean that it wouldn't be, basically it would mean insurances wouldn't pay for it because we wouldn't have enough positives. But you are the person that we will miss, and thankfully you had a cough, and you went and you got screened. Right, right, which is very often the situation. 15% of lung cancers happen in never smokers. Those are different cancers. They're sort of driven by a different, mutational profile, so to speak. We know now that some cancers have sort of one mutation that they live on. And if we can just block that mutation, we can almost, melt away that cancer with some of the targeted treatments that we have now. But non-smoking lung cancer is a different entity. All right. Well, thank you, everyone.
Now, one last little thing to do. Hand on your chest, hand on your belly. Come on, everybody. You can all do it. You got 2 hands, most of you. If you haven't got 2, all right, you're forgiven. Come on. All right, so when you stand in front of a mirror and you take a breath, you should see the belly hand move. It should be the bottom hand, not this. When you're standing up, everything drops. So you should be able to take a nice deep breath with your belly. So you know you're pulling air all the way down. If all your breaths are this, you need to really focus on letting it go. Let your body do what it wants to do, which is a nice deep breath. So it's just, you can do this in front of the mirror, but you can also feel it. Very little up here. Bypass all the little stuff that doesn't have oxygen exchange. Get to the lower parts if you got the parts. Okay? So keep remembering, shoulders back, chin up, and make sure the bottom moves. So now, go forth with all your new knowledge. Enjoy all the wonderful things this life has to offer, one day at a time. Thank you so much.